Good afternoon. Am I audible to all of you?
Yes, sir.
Okay. Today I will have I taken the lecture on topic skeletal maturity indicators to your batch?
No, sir.
Okay. So today I will be taking the topic skeletal maturity indicators. So I would prefer that people give answers, so it will be a more interactive session rather than a monotonous lecture. I see there are sufficient 40, 45 number of participants today. It is very good to see that. So I will start. Can anyone tell me what is skeletal maturity? Can anyone tell me what is age? I will be asking questions in between, and if you have put your attendance and you are not responding, your attendance will not be considered. Do you want me to take specific names? Okay, Yogesh Suryavanshi. Unmute yourself. Yogesh Suryavanshi. Rutuja Kalantri. Okay, so I don't see that students are responding. Do you want this to be an interactive session or just a normal reading session that I'll read all the slides and just go away? Is that fine with you guys? Yes, Pranjali Zadav, unmute yourself. Okay, I will continue with my lecture. Skeletal maturity indicators. One of the objectives for treating skeletal discrepancies is to take advantage of patient's growth spurt, which helps to achieve optimal results within the short period of time. Evaluation of individual biological timetable and identification of period of accelerated growth is essential for clinical decisions regarding growth modulation procedures for skeletal discrepancies. Extraction versus non-extraction options, use of oral orthopedic forces, and planning for orthognathic surgery for skeletal malocclusion. As a result of many investigators have attempted to predict the duration, magnitude, direction, and timing of adolescent growth changes. The developmental status of child is usually assessed in relation to events that take place during progress of growth. Thus, chronological age, sexual maturation characteristics, dental development, dental age, height, weight measurements, and skeletal age are some of the biological indicators that have been used to identify stages of growth. Chronological age is often not sufficient to assess the developmental stage, the somatic and maturity of the patient, so that the biological age has to be determined. The biological age is determined from the skeletal, dental, and morphologic age and onset of puberty. The patient's chronological age is identified as the time period from birth to till date. Morphological age is based on the height. Child's height can be compared to those of the same group of other age group to determine whether they stands in relation to others. Height is useful as maturity indicator from late infancy to early childhood. Dental age is also based on two different methods, tooth eruption and tooth mineralization. Sexual age refers to development of secondary sexual characteristics. This is the indicator usefulness for adolescent growth spurts. Skeletal age assessment of, is often made with the help of hand wrist radiograph, which can be considered the biological clock. 9 developmental stages are there according to Bjork, Crave and Brown. The ossification events are localized in areas of phalanges, carpal bones and radius. So basically, hand wrist radiograph is the most important radiograph that we take for skeletal maturity indication. Orthodontic treatment progresses very quickly during growth spurts, and generally children experience a pattern of fast growth followed by slow growth in late childhood. Then accelerated and peak growth in adolescent, because child begins in sequence of growth at different ages. Chronological age is a poor indicator of child's development. Hand-wrist radiograph is a useful tool for identifying a child's skeletal development. Topography of the hand-wrist radiograph. So this is basically a hand. This is the wrist. It has carpals, metacarpals, and phalanges. Phalanges are distal phalanx, middle phalanx, and proximal phalanx. The nearer to the wrist is proximal, away from the wrist is distal. And these fingers are named as 1, 2, 3, 4, 5. Or thumb, index finger, middle finger, ring finger, and little finger. On a radiograph, you see the same in a similar way. So when you consider just one phalanx, the whole skeletal maturity indicators actually compares the relationship of the epiphysis and the diaphysis. This is the diaphysis and this is the epiphysis. Epiphysis is the tip of the bone which is actually growing, and diaphysis is the bone. So when the epiphysis is smaller to the diaphysis or equal to the diaphysis, or fused with the diaphysis. These three criteria are considered to make a chart of different stages of skeletal maturity indicator. Most commonly used is the middle finger, the little finger, and the thumb, as well as your carpal bones and the radius. This is the radius and the epiphysis and diaphysis of the radius. At last, hand-wrist radiograph, different methods are given using which we can assess the skeletal maturity stage of the patient. The different methods are given. They are Atlas, Sesmoid bone method, Julian Singer method, Fishman method, Hag and Taranga method, O'Reilly's and Carter's method. As I said before, the first stage is epiphysis, shows the same width as diaphysis. Second is capping stage and third is union stage. So most commonly used is the Fishman method, which was given in 1982. It has 11 stages. So in this, the first stage is epiphysis as wide as diaphysis, and this is seen in 3 locations: third finger proximal phalanx, third finger middle phalanx, fifth finger middle phalanx. That is third finger proximal phalanx, third finger middle phalanx, fifth finger middle phalanx. After which there is appearance of ulnar sesamoid, which is stage 4. This is abductor sesamoid of the thumb. It appears, the calcification begins. So if the patient is in stage 1, 2 and 3, you cannot see the appearance of abductor sesamoid. And if the abductor sesamoid is present, then the patient cannot be in first 3 stages, they can be in any of the further stages. The next stage is stage 5th, 6th and 7th. In all these 3 stages, there is capping of epiphysis. In the first step, there was width was same, but there was no capping. In these stages, there is capping of epiphysis. So the locations are for fifth stage, third finger distal phalanx, third finger middle phalanx, and fifth finger middle phalanx. Here it is third, third, fifth. Here is also third, third, fifth. Difference is proximal, middle and middle. Here it is distal, middle and middle. So it is third finger distal phalanx, third finger middle phalanx, and fifth finger middle phalanx. They are having equal size. That is distal phalanx, and middle phalanx. In first part, it was proximal phalanx, and middle phalanx. Then abductor sesamoid, then distal phalanx, and middle phalanx of fifth finger. They are capping. After capping is the fourth stage, where is fusion of epiphysis with diaphysis. This is again, all the 3 points are sealing third finger. That is third finger, distal phalanx, proximal phalanx, and middle phalanx. Here you do not use the fifth finger. Instead, the growth is ended at the radius. When the radius is having fusion of epiphysis and diaphysis, the growth is completed. So in this, it is distal phalanx, proximal phalanx, and middle phalanx. After which the radius, fusion of radius with epiphysis and diaphysis. To summarize the whole classification, first part is 3 stages, which is this. If the abductor sesamoid is not present, which is the stage 4, then the patient can be in stage 1, 2, or 3. Stage 1 is proximal phalanx of third finger is equal. 2 is middle phalanx of third finger is equal. Epiphysis is equal to diaphysis. And third stage can be middle phalanx of fifth finger, the width is equal. Epiphysis and diaphysis. If the abductor sesamoid is present, then you check for stage 8 whether the distal phalanx of third finger is fused. If the distal phalanx of third finger is fused, then the patient can be in stage 9, 10, or 11. If it is not fused, then it can be in stage 5, 6, or 7. So stage 5 is capping. 5, 6, and 7, all the 3 stages are capping. Capping of distal phalanx of third finger, middle phalanx of third finger, and middle phalanx of fifth finger. And if the fusion is seen in 8th stage, then it can be 9, 10, or 11. That is proximal phalanx of third finger is fused, middle phalanx of third finger is fused, and radius is fused. If the radius is fused, then the patient's growth is completed. Stage 4 is the most important part of growth because the most common growth spurt that we utilize in orthodontics is seen during stage 4 for orthodontic treatment. Most amount of growth, 75 to 80% of growth is remaining if the patient is 4th stage. Next method used is cervical vertebra maturity indicator. The first 7 vertebrae in the spinal column constitute the cervical spine. The first 2, the last and the atlas, are quite unique. The third through the 7th have great similarity in maturation changes and can be observed from birth to full maturity. Vertebral growth takes place from cartilaginous layer of the superior and inferior surface of each vertebra. Secondary ossification nuclei on the tips of the bifid spinous processes transverses appear during the puberty. Secondary ossification nuclei unite the spinous process when the vertebral growth is complete. After completion of endochondral ossification, growth of the vertebral body takes place by periosteal apposition. It appears to take place on the front and sides of Todd and Pyle and Lanier and Taylor made measurements from lateral radiograph on the lomocervical vertebral spine. Lamparski studied the changes in size and shape of the vertebrae. The standard method to evaluate the skeletal maturity has been used a hand-rest radiograph to compare the bore of the individual hand with those of the published atlas. To avoid taking any additional X-rays, some researchers sought to relate hand maturation with dental and skeletal feature other than the bones in the handrest. Use of cervical vertebrae to determine the maturity. In 1970, Lamparty concluded that the cervical vertebra, as seen on the routine lateral cephalogram, were statistically and clinically reliable in assessing skeletal age at the handrest technique, similar to handrest technique. So, the cervical vertebrae have 6 stages: stage 1, 2, 3, 4, 5, and 6. The stage 1, inferior border of the bodies are flat and the superior borders are tapered from posterior to anterior. Inferior borders are flat and superior borders are tapered from posterior to anterior. In stage 2, a concavity has developed in the inferior border of the second vertebra. The anterior vertical height of the bodies have increased. That means the concavity has increased on the second vertebra and the anterior height of the vertebra is increased compared to the previous stage. In vertebra 3, in vertebra 6, it is still less. From wedge shape, it is progressing towards a more rectangular shape, from which it will progress more towards a square shape. The concavity at the lower border is it begins at second vertebra, then progresses to third, then fourth, then fifth and sixth, and there is increase in the concavity as the growth matures. So this philosophy is used for measuring at which level of vertebra what type of changes are seen. That is anterior posterior height, wedge shape to rectangular shape to more squarish shape. Stage 3, a concavity has developed in the inferior border of the third vertebra. The other inferior borders are still flat. Stage 4, all bodies are now rectangular in shape. The concavity of the third vertebra has increased and a distinct concavity has developed on the fourth vertebra. Concavity on fifth and sixth are beginning to form. Stage 5, the bodies have become nearly square in shape and the space between the bodies are visibly smaller. Concavities are less defined in all six. See here there are more spaces in between the bodies. Here the spaces have been reduced because of the growth of the same. Okay. Similarly, another classification which names these stages, that is initiation, acceleration, transition, deceleration, maturation and completion. Same things are seen on the cervical vertebra 3. And the cervical vertebra 3 shows a wedge shape without concavity. It is initiation. When it shows increased anterior height with developing lower concavity, it is stage 2. In stage 3, it is rectangular with increased lower concavity. In stage 4, it is squarish with increased concavity. In stage 5, it is a vertical rectangular with increased concavity. In stage 6, completion, it is a vertical rectangle with increased or deep concavity. The similar photographs, wedge-shaped vertebra, increase in anterior height, rectangular, squarish with increased concavity, increased square with increased concavity, and vertical rectangle with increased concavity. These are the same stages that I explained. So when we compare the stages of hand wrist and skeletal vertebral maturity, the percentage of growth remaining is mentioned here. When the hand wrist is in first and second stage, the cervical vertebrae are in initiation stage and 85 to 100% of growth is remaining. Similarly, when the hand wrist is in third to fourth stage and cervical vertebra in acceleration stage, 65 to 85% of growth is remaining. Fifth to sixth stage of hand rest or transition stage of cervical vertebra, that is 25 to 65% of growth remaining. These three stages are more important to start with functional appliances or orthopedic appliances because you can utilize the maximum growth. After stage 7 and 8, when deceleration is going on, only 10 to 25% of growth is remaining. At this time, less effect of orthopedic or functional appliances is seen on the skeletal. More of dental changes can be made. In stage 9 and 10, only 5 to 10% of growth is remaining, and major orthopedic or functional changes cannot be achieved during these stages. In stage 11, completion, there is 0% of growth remaining. Hence, you have to go for surgical line of treatment and functional appliances and orthopedic appliances cannot be utilized. Similarly, there is a tooth calcification method which is used for determining skeletal age. This is Nolla's classification. When you see a OPG radiograph, you see for lower canine, if you see these stages, that is absence of crypt, there is nothing present, and there is a crypt present. An empty hollow circle is seen on the radio recency is seen on the OPG. Initial calcification, you can see the beginning of calcification of the enamel. Inside stage 3, one third of the root is completed. Sorry, one third of the crown is completed. It is miswritten here. In stage 4, two-thirds of the crown is completed. In stages of stage 5, crown is almost completed. In stage 6, crown is completed. All of these findings we are seeing on a OPG or a IOP of the canine tooth. In 7th, one third of the root is completed. In 8th, two-thirds of the root is completed. In 9th, almost root is completed but the apex is open, and in 10th the root is completely formed with apical closure. These stages can be used for assessing the growth of lower canal. Okay, thank you for your patience. Have a good day.